Okay, welcome again. Thank you so much for joining me this afternoon. We have a lot to talk about today. So, typically, when we present Is Medicare Advantage right for me? It can either be for somebody that has Medicare supplement right now, or it can be for somebody that has Medicare Advantage right now. So there's lots of things to consider in here. We are also going to cover the aspects of what is happening with Medicare and why is it becoming more expensive as time goes. So I really appreciate you joining in, for watching, for listening, and for working to understand how all of this fits together. I'm Lisa Kennison, owner of MVIP Inc., Trozan Insurance, and we really appreciate your participation in this. All right. So, my first thing that I usually recommend to everybody is be really, really careful about misinformation. So, when we have 800 numbers on the television, or if someone calls spontaneously to offer you a plan via phone, those are definite red flags. You really need to be careful of those aspects. Most of those people are trying to gather your information to sell it to a lot of other people. And that's a really rough thing. After it's happened to you, you're going to get 12 to 15 phone calls a day. So just really watch out for that. Additionally, there are new, well, not so much new, but some really good mailed scams out there. So you'll receive an envelope in the mail. It will look like it came from the US government, Social Security, or Medicare, and it's really not from those entities. So you'll find in that note on that piece of paper or even outside on the envelope, it says they are not affiliated with the government, even though they've got that really nice seal up there at the top of the envelope. So don't follow those things. Don't look at them. Just know they're trash for you. Now, if it is really from Social Security or Medicare, please do open those. That's important. You don't want to miss that because the only way that they contact you is through the mail. So that is an important aspect. When we talk about changes to Medicare and what is happening with Medicare, the very first thing that happens every year is that Medicare sends out something called the final rule. The final rule is what Medicare says everybody downstream from Medicare should be doing. So that gets handed to the insurance companies, who then in turn interpret it and hand those rules down to the brokers, to the salespeople, to the service people, everybody out there. And this is how we are supposed to operate compliantly. So we have a lot of standards that we have to live up to and make sure that we are doing it just right. And as most of you are very well aware of, we really are your trusted source for unbiased information about Advantage plans. If you go directly to the company to look up their plans, you're going to get a lot of the fluffy things that come from that company. They're telling you all the good things about the plan. When we walk side by side with you, we get to see how can it go wrong? What are the things that don't necessarily work for people? And we have the ability to be honest and unbiased with you. We're always reading, learning, listening, and interpreting for you so that you're getting the best product that can possibly fit you. Right, now we're going to get into some meat and potatoes here. So, the history of Medicare, we're going to go through a brief history of it. Where did Medicare Advantage plans come from? Some of you already know this because we've talked about it in our sessions quite a bit. Medicare is a law. It's difficult to change laws. The baby boomers, huge group of people turning 65, also known as the silver tsunami. Medicare really realized this was going to happen, that it was going to cause a lot of grief for Medicare itself to have all of these people turning 65 daily. And so they went to Congress. They created an act called the TEFRA Act, And that is what authorized Medicare to contract with private health insurance companies. That's like United Healthcare, Humana, Cigna, Aetna, Devoted, all of those. The contracting basis of this is that those plans would accept full responsibility for your health care, for the costs of you in exchange for what Medicare would normally have set aside for you. So Medicare earmarks this little pile of money for you every single month. That is for your care. If you sign up for Medicare Advantage plans, then they transfer that pile of money over to that private insurance company to take care of you. This all started in the 1980s, but you can see how long it took for Medicare Advantage to really gain some momentum. And part of it was they weren't good at first. They were pretty wretched, frankly. They were not very good. And in all reality, when we look at any kind of health insurance plan, that is how it starts. It is a rocky road. So Part C plans do have to provide Medicare covered services, but they may not look identical to Medicare. Many people will ask me this question: how can I have something that I don't pay for? The zero premium question. And it relates directly back to what I was explaining before. Even though you're not handing money over to the private insurance company, that company is getting the Medicare monies from you. So there is a monetary exchange there. That then defines the true definition of insurance, the transfer of risk for something. So you're paying something through Medicare to have that policy. Right. The goal of Medicare plans. So we've got original Medicare, but as we've spoken about before, original Medicare was never meant to cover everything for you. It was out there to help people pay for the costs of their care. The goal of our supplements or our Advantage plans, next screen, is that we need to limit what you will spend in a catastrophic medical event, because Medicare itself, original Medicare Parts A and B, does not limit what you spend. It is an open-ended question of what would be your max out of pocket. There is no answer to that. So these goals, there's some that represent you and there's some that represent Medicare. The goals that represent you, it's another choice for you. It gives you additional benefits. Original Medicare does not cover dental, vision, or hearing, and there's no plan for them to do that right now. There's been talk about it in the past, but the fact that our Medicare trust fund is dwindling and will run out at some point if we don't make changes pretty much points to the fact that they're not going to add extra coverages into Medicare itself. The other goals that it represents for you would be cost savings. It's that safety net in times of need. But there are also goals that help Medicare. It provides choice for Medicare beneficiaries, which then corresponds to you liking Medicare more. When we have more choices, we tend to like things. It does save money, time, and resources for Medicare. To allow other insurance companies the responsibility to care for you, it opens up Medicare to do what it's doing, but better. I'm a little slow on changing the page here. It's not working so great. So just a minute ago, I said that they have to provide, Medicare Advantage plans have to provide the same coverages that are in Part A and B. It's functionally equivalent, but not exactly the same. So you're going to see some things in Medicare Advantage where it says you do owe 20% of your outpatient services. That could be chemotherapy or radiation, for instance. When we owe 20% of it, though, we still have a cap to what we have to pay. We do not have to pay forever that 20%. Now, if you look at a typical zero premium Medicare Advantage plan, that typical Medicare Advantage plan is going to have roughly $1,500 to $2,000 or a hospital admission of a week or longer. And the hospital deductible for Medicare itself is right in that $1,600 range. So some of the things you can really correlate and they look really similar. But otherwise, they are maybe not completely equivalent, but they are what's considered functionally equivalent. As well as your preventive care services, those are all part of a Medicare Advantage plan as well. When we look at this functionally equivalent coverage, we've got the same preventive care. There's also minimum care required. So there are set standards that Medicare puts out there, and Medicare Advantage has to follow that. You will see a lot of things on the news right now about uncovering details of what is going wrong with Medicare Advantage. And we'll talk about that. We're going to discuss that right here after we get through the rest of the presentation. Here's another example, another comparison of original Medicare to Part C. So once again, you've got Part A and B with original Medicare. Medicare Advantage is called Part C. C like a combination plate. And what it contains is Parts A and B. It usually contains Part D for drug, and then additionally your dental, vision, and hearing. So what it costs, you can see some things here. These are a little bit older. They're from 2022. Part B costs are actually at $174.70 right now. So it doesn't matter whether you have original Medicare or Medicare Advantage. You're still paying $174.70 unless you have a Medicare Advantage plan that has a rebate on it. We do have Medicare Advantage plans that allow rebates to you for your Part B premiums. Those rebates are typically, $40 to $50 a month, but we do have a plan out there that's over $100 in rebate. If you're buying a rebate plan, then what's going to happen is you're going to get that money back into Social Security, but your coverages are going to be dialed down. You're essentially paying less for your Medicare Advantage plan, and thereby your coverages are lower. So you're responsible for more of the costs. Medicare Advantage is provided by the private insurance companies, and Medicare monitors that. They monitor the company's performance in 53 different standard points. Those points are evaluated through something called the CAHPS survey. The CAHPS survey asks questions about or from the people who actually have the plan. And they will ask about how satisfied you are. Does it seem to be working for you? How has the pharmacist been able to work with your insurance company? That 53-point scale comes through in star ratings. And every single plan out there, it's not company-wide, it's not Humana-wide, United Healthcare-wide, it is per plan. They all will have a star rating once they've had enough experience to go through the CAHPS survey. Okay, page, there we go. So CAHPS is this, and it determines not only the star rating, but once the star ratings are published, it also determines the amount of subsidy the plans get from the federal government. So if they're not performing well, they don't get the full subsidy to take care of you. So that's a twofold thing. The better they are at taking care of you, the more money they get to take care of you. But you can also see that if you're going to go for a 3-star plan or a 2-star plan, you might not get all the service that you're wanting, or you might not get the care that you're wanting. So that is a very important thing to look at. A five-star plan is the best. And last year we lost our five-star plan. The plan's still there, but it just doesn't have 5 stars anymore. Now, down in the Boulder and Denver area, there is a plan that is still a five-star plan, and that should be moving to northern Colorado this fall for a January 1st, 2025 effective date. So what we have here is monitoring at federal, state, and private levels, which I think is really kind of neat. It's a nice checks and balances system. However, that doesn't make it fast. So that Medicare rule comes down, that gets spread out to the insurance companies. Additionally, with the final rule, they will tell the insurance companies how much money they're going to get for each person that's insured with them. That then allows the insurance companies to create the actual Medicare Advantage plan that they're going to offer to people. And they have to be able to prove then to the state division of insurance, that they're going to be able to pay for that care according to what they've put out there. They have until, I'm trying to think. I think June 4th is the last date that they can submit that. So there's some pretty tight turnaround between the end of April and June 4th when these companies have to have their policies situated. It's not just for new policies, but also returning policies. So if you have a drug plan right now, or if you have a Medicare Advantage plan right now, those companies are submitting all of that information to the state division of insurance. So changes to premiums, copays, co-insurances, max out-of-pockets, those are all being reviewed. Compliance is another aspect of this. Compliance, that is the rules that are followed, but are they enforced? So we'll talk a little bit more about that and how Medicare Advantage was born and how it operated in the first few years. But there's federal and state compliance laws, as well as compliance within the insurance company. So who's really responsible for making sure that everybody that sells insurance is compliant is the insurance company, but also the state. We have to have state insurance licensing. Then we also have federal certifications that allow us to work with Medicare people. So it's quite a lot, in all honesty. That's a big process. Then another thing for you in these plans is grievance and appeals processes. Not everything goes as we expect it to. And I can honestly say that there have been problems with every single type of plan and every single company. Sometimes we just run into, it seems like one person just has a slew of bad luck over and over and over again. And we need to step in and help with some of those consumer issues. There are grievance and appeals processes within the insurance company. So you can file a grievance against the insurance company through the insurance company. Or you can do it through the Division of Regulatory Agencies in the Division of Insurance. Or you can do it at the federal level directly to CMS. We have helped quite a few of our clients with these grievance and appeals processes. So you're not alone out there. We can help you. We've got template letters. We can help assist with that. If you're having serious problems, please let us know. The only way we know how to help is if we know what's going on. So we've talked about how the insurance companies and Medicare itself can change. And now what we want to talk about is what kind of changes we've seen in our medical systems since the 50s and 60s. Is our medical care better or is it worse? I guess it's going to really depend on what you're looking at. Absolutely, we've made big changes to what kind of medical care we get, and our survival rates are much better. But when we talk about the word care, I think there might be a little less care out there in the world. People don't have enough time to meet with you as a patient. The doctors and the facilities don't seem to have quite as much care as they did, and nobody's bringing you a pot of chicken noodle soup. It just doesn't happen anymore. Is it more expensive or less expensive? Again, that can really depend on what we're talking about. For many years, we didn't have Medigap plans, we didn't have prescription plans, and we didn't have Advantage plans. So when we had original Medicare, if someone became seriously ill, that could be detrimentally expensive. It's not necessarily cheap today, but it is also not as expensive as it was, unless we start talking about things that are not covered by Medicare at all. Then we can get into some really big expense. Is our medical system efficient or wasteful? Probably a little bit of both. We're striving for efficiency, but in that there's a lot of waste. There's also fraud and abuse that can happen in there. So that's a big change out there. Then how does inflation affect your costs? So increasing medical costs, skyrocketing drug costs. How does that affect what you have to pay? Additionally, I like to think of the word inflation a little bit differently. Inflation can also mean, and I give this example a lot, I'm not downing Kohl's, but when you go to Kohl's, everything is marked up so they can mark it down. That same thing happens with our medical care and our dental care. They have inflated prices so that they can then negotiate with the insurance companies and mark it down to that negotiated price. So there are two different routes of inflation there for sure. So let's take a little step back and look at changes and laws. Laws are difficult to change. It is a slow process. Our Congress has to agree to make changes to laws. Remember, Medicare is a law. Healthcare is extremely rapid growth with lots of discovery, very fast paced. Care models are different on every single level, and there are fewer and fewer providers in our system now. People are not growing up saying they want to be a doctor. Many of our doctors retired during COVID because the stress was so great. There's a lot more expected of our medical providers than there ever has been as far as numbers go. Medicare is also a very large system, and it's difficult for it to move and adjust. It's a reactive model of care. So it's going to be there when you have big claims. Absolutely. It's going to pay out for you. It's not terribly proactive, though. It's not providing you with all the tools to take care of yourself. Medicare Advantage is more able to accommodate current changes in our healthcare systems. It allows more creativity in care and a more proactive approach to healthcare. But what we'll see is that there have been lots of problems as it's gotten going. So it is going to be another discussion point coming up. The next thing we're going to talk about is the Inflation Reduction Act of 2022. If you recall, this is some Biden administration, and what it was aimed at doing is helping with inflation. Many of the things that were included there directly related to Medicare. So we're just going to pick out those few things out of the 1,300 pages that are in it. We're going to see who benefits both today and tomorrow, and who pays today and tomorrow. And I think it's probably not going to be the best news out there for a while. So let's talk about it. So here's a timeline of the prescription drug only provisions for the Inflation Reduction Act. And that's where it was really, really diving into the Medicare realm, trying to make sure that we lower the cost of prescription drugs, that we lower the consumer pricing for prescription drugs. So it was passed in 2022. In 2023, we already saw some changes, limiting insulin copays, reducing costs and improving coverage for vaccinations, requiring drug companies to pay rebates if their drug prices rise faster than inflation. Boy, everyone was excited about that one, that very last one that I mentioned. As it turned out, those rebates were not nearly as high as what the drug companies actually make off of things. So there was not a whole lot of care from the pharmaceutical companies in this because they're like, I'll easily pay the fees. Let's just raise the pricing. They rose that pricing pretty dramatically in that year. Then this year, we've had some positive movement for the consumer. So before, we've had 4 phases of drug coverage. There's the deductible phase, initial coverage where we may have copays or coinsurances, the gap coverage where we pay 25% of the medications, and then the last phase is the catastrophic coverage where you paid 5% of the cost of the medication through the end of the year. In other words, there was no limit again to what you would spend on your prescriptions. It hadn't existed. In 2024, they eliminated the catastrophic coverage phase. Not really eliminated it, but eliminated the 5% coinsurance that you needed to pay. So that went to 0%, which was a really good thing for people who have extraordinarily high drug costs. Then it also expanded eligibility for LIS, or low income subsidy, for Part D. And instead of having multiple levels of it, we went to one single level of 150% of the federal poverty level. In 2025, the next positive thing for consumers is that you will have an out-of-pocket maximum, or cap, of $2,000 for your medications. Another really, really good consumer item. There is one problem with this, though. So the other thing that the IRA wrote into the Medicare law is that they will start to negotiate prices for certain drugs. Those drugs are what Medicare spends the most amount of money on over time. And so in 2026, we're going to have 10 Medicare Part D drugs negotiated. In 2027, 15. Then in 2028, we'll have both Part B like boy and D like drug negotiated. And you see that going on and on. This all looks like good information at this point, right? The only problem is instead of having top-down legislation, we had bottom-up legislation here. This right here, the rebates from the drug companies, was supposed to alleviate some of the pain that the insurance companies would be feeling from this. And I'll show you what that looks like in a couple more screens. But because we're not actually implementing negotiated drug costs until 2026, what's happening is the consumer is paying less for things. The government is going to be paying less for drugs. And the pharmaceutical companies are still able to raise their prices up, up, and up. So who gets the pinch in the middle? In this case, it's the insurance company, which will then trickle down to the consumer. So right here, this sentence limits Medicare Part D premium growth to no more than 6% a year. This has not been solidified yet. At this point, we are expecting that for the 2026 plan year, that will take effect. We saw already huge price increases on prescription drug plans last year with most of our plans, except for one that went to 0 premium. There's a reason for that too. This year, we're expecting even higher increases because the insurance companies are saying they're not going to let us raise prices more than the 6%, and it's coming soon. So we need to do as much as we can right now to stay on top of this. So let's dive a little bit deeper. We're going to talk about that negotiation timeline. So if we pass this in 2022, why is it taking until 2026 for that to take effect? Those first 10 drugs negotiated. Well, the first thing that happened is by September 1st of 2023, Medicare had to decide which 10 drugs are we going to try to negotiate on. Then they began that process of negotiating October 1st. And you can see here almost a year later, not until August of this year, will we actually see that negotiation process come to an end. Then they will publish maximum fair prices as of September 1st. But then the drug companies do not have to adhere to that until 2026. So we've got a lot of forgiveness for the top there. A lot of forgiveness. Same thing happens then for that next set, 15 drugs. That will be in 2027. Now, this page has a ton of information on it, but I'm going to point out what you should really be seeing. This is what it means to who's paying what in which year. So by last year, basically what happened is, if you look at this, you are this orange color. So you pay 100% in your deductible phase. Then in initial coverage, it roughly equates to you paying 25%. In the coverage gap, we all know that's where you pay 25% coinsurance. So you have 25% there. And then catastrophic, you had 5%. So let's take a look at this year now. Same thing with the deductible. You have to pay 100% if you do have a deductible on your plan. 25% in initial coverage, that really didn't change. 25% in gap, no change again. But up here, you don't have that 5%. Now, when we get to 2025, you're going to see something different. You've got 100% of the deductible. You pay roughly 25% of your drug costs when you're cost sharing with the insurance company. But then when you hit this red line right here, $2,000, you won't pay any more. So that is your max out of pocket. So for you, yes, there's some savings. Overall, what they're saying is roughly $1,250 per year for those people with the most expensive drugs. Now I want to show you what's happening with Medicare, because part of all of this legislation, part of everything that's out there right now is really descriptive of the Medicare Trust Fund having an expiration date. The trust fund is everything you've paid in throughout your years of working to the Medicare Trust Fund to be able to pay part of your health insurance once you're retired and on Medicare. So Medicare has recently updated that to 2036. As of that date, if nothing else changes, they will run out of money. And there won't be enough money for Medicare at that point. So part of the IRA Act was to reduce Medicare's amount that they're spending on drugs as well. And so this navy blue color right here is Medicare's spending. Traditionally, Medicare doesn't spend anything on those Part D, like drug, prescriptions that you pick up from the pharmacy until you are in that catastrophic phase. So you can see they're paying 80% there. That's pretty substantial. Today, in 2024, they're still paying 80%. But look what happens when we get to 2025. That drops to 20%. That is a huge, huge difference. And you know you're paying a little bit less, and we know that Medicare is paying less, massively less. So what does that mean for the insurance company, which then in turn flows into your premiums? Part D plans, that's the private insurance company providing your prescription drug coverage. It's this blue color right here. So during initial coverage, the insurance company pays 75%. That was in 2023. 5% then in the coverage gap, and 15% up here. And in 2024, the 75 and the 5 really stay the same. They're amping up a little bit here at 20% now. But look what happens in 2025 and why our insurance companies are really raising rates. So they pay a little bit less on the front end. But instead of that roughly 20% they have been paying, they're now responsible for 60% of the drug costs. Insurance companies are a little bit unlike our federal government in that they can't print their own money. They have to stay solvent. That is a requirement for that company to operate. And because of that, they are expanding the premiums to really take care of that. They just have to. So let's dive in a little deeper to that trust fund. As you heard me say, it's set to be depleted by 2036. They actually extended that by 3 years. And part of that is because of the Medicare, the Inflation Reduction Act that came through. So we're going to talk a little bit more about this trust fund and why it is the way it is. So it truly does finance your health services for beneficiaries of Medicare. It also helps with the program for the elderly, the disabled, and people with qualifying health conditions. It is financed solely by payroll taxes and then additionally by general revenue sources. More people are turning 65 daily than ever before. So that's called the silver tsunami. This is a little bit outdated at 10,000. We're currently at 12,000 people daily. When Medicare was originally written, it was 3,000 people daily. So that is a massive change. What that all means is not just that there's more people flowing into the Medicare system, but there's also fewer people working and paying into the trust fund. So if it's your payroll taxes that we're paying for the trust fund, and we have that many people leaving the workforce, that means then there's less and less money coming into that trust fund. Additionally, it was the baby boomer generation that thought it was great to be able to make a lot of money up front and then retire early. Retire at 50, 55, or even 60, no longer paying into payroll taxes. So very, very confounding situation. Double whammy is what I call it. Now we're going to diverge a little bit from that Medicare trust fund. We're going to talk about the news reports of abuse in Medicare plans. So there's been a huge amount of press out there about Medicare Advantage plans not approving pre-approvals, not doing their prior authorizations, having automatic denials in place for a certain number of those. And this is the section that I call the kid in the candy store. When you leave a kid in the candy store without anybody to tell them, no, don't, no, you can't have that, you can't have that, then it can lead to abuse. When we talk about Medicare Advantage, a lot of people are concerned about these rules, and I don't want these rules. Well, unfortunately, these are rules across all of Medicare. This is not something that is particular to Medicare Advantage. If you have original Medicare and a supplement, it's the same thing. Pre-approvals and prior authorizations are part of that process. What went wrong for Medicare Advantage plans is that they tried to become somewhat automated. And when that automation happens, you have certain denials that automatically go up based on certain criteria. If you think of it as in setting your cruise control, they set their cruise control too high on the denials. So too many denials were going out. which then caused kind of a backlog of everything because then everybody's appealing these and they're going through more and more work to have to actually approve the ones that need approving, and things get backlogged and it takes more and more time. Well, Medicare went through the same conundrum when it was young, 20 years old or so. How do we automate this process with all of these insureds? How do we get this moving smoothly? And so CMS really worked out the kinks, and they've got a good system in place, very quick and automated. After many years of CMS, the Center for Medicare Services, not enforcing whether these denials of pre-approvals were really what they were supposed to be or whether they were too much, CMS acknowledged that they were not enforcing this. And now they're working to compliantly improve the process with the Medicare Advantage plans. Along with this, I give the caveat of please read multiple sources for your news articles. If you like to watch Fox News, watch something outside of that box a couple of times. If you like to watch NPR, try to watch Fox News for a little bit. I like to read things with a very scientific eye and look at both sides of it. How did we get here? This is a problem. Okay, who's telling you that it's a problem? Do they have the background to back that up? There's a lot of sensationalism in our news reporting on both sides. This is not unique to one side or the other. So please read multiple sources and ask lots of questions. Automation really is needed in Medicare. The numbers are simply so large, it's not going to operate any other way. It has to have lots of automation, but with that automation, we need to know that it's working well and it's working right. So who is responsible for enforcement of this? It is Medicare. They need to do the monitoring and make sure that the private insurance companies that they're trusting to take care of you are doing it the way they want it done. It's just like hiring a babysitter. You don't hire someone that you expect is going to fail. You hire someone that you think is going to do a good job and care for your little one. So here we can go through some pros and cons of Advantage plans. There are just as many pros and cons, and they're all different per person. Overall, when we look at Advantage plans, being a proactive healthcare system can be a pro for somebody, but it can also be a con for some people. It really depends on what that person is looking for. Complication of how the plan works. That can be really nice. It can be cost saving for you, where not everything is the same price, but it can also be confusing and overwhelming. And so, again, that can be on either side of the pathway with pros and cons. Medicare itself with a supplement plan can be very easy to manage, but one of the areas that it's not good at is care coordination. So if you're needing to find other doctors out there who are in a specialist realm, unless your primary care physician is really good at that, some of them are and some of them are not, you may have a tough time ferreting out who you can go to next. Whereas with Medicare Advantage plans, they have care coordination built into the plan to help assist you with not only finding the physicians, but also getting in to see those physicians that you need to see. So there's so many pros and cons, and I definitely encourage you to make your own T-scale here. Put pros and cons on there. Start listing your own there because it is such an individual decision and such a big topic for people. And even within the same household, you might have different pros and cons than your spouse. It really depends on the individual person. That's why Medicare is an individual plan. At this point, I'm going to go ahead and open up the chat for you that you're able to type questions if you have any questions right now. If you go down to your meeting controls, you're going to see a little bubble, like a cartoon bubble with talking in it, just like this guy over here with the question in. You can click on that and you can type in a question. Additionally, there are lots of questions that come up after you have some time to kind of absorb this, talk about it, and you can always call us. You can always type in a message through email. Let us know what you're thinking about. What are you concerned about? What kinds of thoughts do you have about this? Are you concerned about your current plan? Are you interested in another plan? The other thing that we're really working on this year, we've done tons of training on this in the past few months, but we're really working on repackaging your healthcare plans so that we can find that really specific coverage that hits all the needs you have. Some of the things we've learned about, no matter how good our Medicare Advantage plans are, they're still not covering everything that some people want covered. No matter how good our Medicare supplement plans are, they're definitely not covering everything that's out there. So when we talk about dental, vision, and hearing on a Medicare supplement plan, you don't have it. International travel on either type of plan, it's important to look at something else. That international travel coverage is just not comprehensive. When we talk about recovery care, what is recovery care? Well, most people anymore survive stroke. Most people survive heart attack. Most people survive cancer these days. We have so many people living after these issues. How do we recover though? Medicare itself is really good at patching you up, putting you back together, but not necessarily getting you back to where you were afterwards. So, there are plans that can help you recover in your own home or give you the flexibility that you can decide, is a skilled nursing facility better or is home care better? There are plans out there that pay out in case of a cancer diagnosis, a lump sum cancer benefit. And then, of course, we also have, if you're not surviving, we have those final expense policies that cover your funeral expenses that pay out within 48 hours so that a loved one does not have to put that on their credit card. We can review all of the different policies that you have to see where are your gaps. Many of our clients have long-term care policies, but do you know when it kicks in? Do you know how much time you have to go before you actually have coverage for things? And how long will it pay out? Does it pay for somebody to come into your home to take care of you? We can review all of those aspects for you and give you some ideas on what your gaps are so you know what they are, and then you can make really educated decisions. Okay, guys. So I'm going to go ahead and zip out of here. If you do have a question, I will hang out in the background for just about 5 minutes for any questions that come through the chat. But if not, I want to thank you very much again for taking this time out of this beautiful day that we had and sitting in on this discussion. It's a very vast topic and lots of things interplay together here. So thanks so much, guys. Have a great afternoon.